नेक्स्ट डे सद्योवरणचिकित्सा व्याख्यास्यामः अतः सद्योवरणचिकित्सितं व्याख्यास्यामः यथोवाच भगवान् धन्वन्तरिः धर्मपतां वरिष्ठः वाग्विशारदः विश्वामित्रस्तं शिष्यं ऋषिं सुश्रुतम् अनुशात् नानाधारामुखैः शस्त्रैः नानास्थाननिपातिकैः नानारूपाः व्रणाः ये स्युः तेषां वक्ष्यामि लक्षणम् आयताः चतुरस्राश्च त्रस्राः मण्डलिनः सदा अर्धचन्द्रप्रदीकाशाः विशालाः कुटिलाः सदा शरावनिम्नमध्याश्च यवमध्यास्तथा परे एवं प्रकाराकृतयः भवन्ति आगन्तवो व्रणाः दोषजा वा स्वयं भिन्नाः न तु वैद्यनिमित्तजाः. Now the chapter starts with the prayer of the student to the teacher, like you have to teach me, that's all. And the causes for the wounds, the fresh wounds or sadyovrana, could be due to different varieties of injuries, like either it could be due to the instruments, surgical instruments, or it could be due to the fall, or it could be due to the wild animals, that could be injury. And based upon the appearance and the shape of the object which produces the injury, the impact of the injury would be varying. In the present day situation, we generally classify the injuries into two categories: sharp, penetrating injuries and the blunt traumas. Now, that's exactly the point. Like nipata, the pulp would be producing the blunt trauma. And then the shapes of the wounds would be one of the important criteria. Whenever we go for the management of the wound, the shape of the wound is a very important criteria. If the shape is such that it can be sutured well and the edges can be approximated, we call them as the tidy wounds. Whereas if the shape is such that it cannot be sutured well and there is some dead tissue around, then we call it as untidy wounds. Now, Sushruta has categories, those tidy and untidy category, with a different nomenclature. Ayataha, that's the rectangular, Chaturasraha, square, Trasraha, triangular, Mandalinaha, circular, Ardhachandra, semicircular. These are certain varieties of the tidy wounds, whereas Vishalaha, that's the wide wounds, Kutilaha, irregular shaped wounds, Sharava Nimnamadhyaha, where the central area of the wound has lost the tissues and hence is depressed, or Yavamadhyaha, again the depressed wounds where the tissue loss is quite significant. These are the untidy wounds, and these are the different possibilities of the shapes of the agamturana, wound produced due to the external trauma. Whereas doshajaha swayam bhinnaha, the lesions or wounds produced due to the rupture of the pus from a body would have the different names. But none of these wounds will be holding good for vaidya nimitta javrana, surgical wounds. In the surgical wounds, the situation is something different because it's a controlled situation where each of the tissue is identified and you go for the dissection plane wise. Whatever we discuss in the sadyovrana is not completely applicable for the surgical wounds. Of course, certain of the principles are applicable, but certain of those issues which are related to the complications of the sadyovrana may not be applicable. In the present day situation, we classify the wounds into mainly, the wound is classified into acute and chronic wound. Acute wound is generally the sadyovrana, chronic wound is the dushtavrana. And again, it could be classified into tidy and untidy based upon the shape, or the classification also could be made out by either based upon the wound thickness, presence of the complexity, that's the involvement of the other organs or the tissues, or the age, that's whether it's fresh or chronic, and the origin of the wound based upon the shapes. Like when it comes to the shapes, it's the same superficial. Incised is the bhinna vrana, crush is the kshata vrana, lacerated it's the pichita vrana, and stab is again incised wounds, and continuous is again the kshata vrana. Secondary is as a complication of the wound as such. That's how it can be identified. And of course, the other way classification would be based upon the thickness. It could be superficial or partial thickness or full thickness, depending upon involvement of the skin and the deeper tissues. And when there is some other organ involved, it's not only one organ involved, then it's a simple or combined. That's how it's classified. Now, Bishak Vranakrityo hi namoham adhigachyati Krisham Durdarsha Rupeshu Vraneshu Vikriteshvapi Ananta Akriti Agantuhu Sadbishakbihi Puratanihi Samasato Lakshanantah Shadvidah Parikirtidah Chinnam Bhinnam Tata Vidham Shadam Pinchidamyam Cha Drishtamahutsata Shashtam Tesham Vukshami Lakshanam. Now, if you know the correct shape, that a knowledge of the correct shape of the wound is quite important to have a good result. The untidy wound has to be modified into a tidy wound by modification of shape, and then it can be sutured so that you can achieve the primary healing even in case of an untidy wound. And that's an extraordinary skill. There are many, later on in some other sessions I will show you the examples of that also. How to convert a untidy wound into tidy wound. It is purely a skill-based knowledge, where based upon your practical common sense, that wound has to be modified in such a way that it can be sutured well. Then, because the shapes of the wounds could be of innumerable variety, and it cannot be just described in a comprehensive manner, Sushruta has classified them into 6 categories, and those are Chinna, Bhinna, Vidha, Kshata, Pichita, and Ghrista. These are the 6 varieties of the wounds. Now, types of the wounds again, as per the shape again, now we classify them as cut wounds, that's the Chinnavrana, and stab wounds, and stab and cut, of course you have mixed up them together, and chopped is again the Chinnavrana, crush is the Ghrista or the Kshata type of the wound, and of course surgical wounds is something different. This is how it's classified. The first is about the Chinnavrana. Chinnavrana, of course, we have referred to these issues when we have discussed about the Chedana Shastra Karma. There again, the same issue. Tirashchinam Rujuruapi Yovranaha Ayat Gatrasya Patram Tapi Chinnam Ittipadishyade. A wound which has produced a wider surface with a significant tissue loss, Gatrasya Patram. The tissue loss is there, and a separation of that tissue from the base part of the body, and which results in a wound which is wide, and the shape or the surface could be either wide or it could be straight or maybe oblique. Tirashchinam is oblique, Rujuhu is straight or horizontal. The shape of that could be any of that. So such of the wounds where there is a tissue loss, cut wounds, where a part of the body is separated, that are what we call as amputated wounds, the other way. Such wounds are considered as the Chinnavrana. And in these conditions, the tissue loss is one of the important issues, and the shape of the organ to be maintained is quite difficult. Of course, now in the present situation, we have certain examples of the tissue parts which are re-established or resutured or revived, or otherwise it always results in a stump which doesn't have the normal appearance. Then you may have to use a prosthesis. So these are all the issues which you have to consider whenever you treat a wound where the amputation has occurred. If possible, that portion of the part, that part of the body can be revascularized if possible. If not, you have to create a stump in such a way that the functionality of the patient can be better, or maybe that functionality can be improved with a prosthesis. So the shape of the stump at the end of your treatment is one of the important criteria which you have to consider when you treat an excised wound. Then Kunta Shakti Rusti Khadgagra Vishanadivi Ashaya Hata Kinchit Sravettadi Bhinna Lakshanam Mutyade. These Kunta, Shakti, Rusti, Khadga, Vishana, these are the different types of the weapons used in Indian philosophy. You will have lots of examples and lots of descriptions of the weapons used in warfare, and there is a one specific description of Ayudha Purusha, which is a Sudarshana, or the other way the name is Sudarshana, one of the avatar of Vishnu, who is supposed to carry all sorts of the weapons. Now, this is the image of course, somebody has to draw this image, and the image of that Ayudha Purusha, that's the Sudarshana, there you have these all the weapons. Kuntayudha is the one which has a rod, and then there are some spiked appearances, spiked ball-like appearances. Shaktayudha is just a triangular piece of the metal which can be pierced through, as you see over here in the last acid. Then the wrist is a small sword which can be pricked in, and kharga the long sword, massive. These are Vishana is the horns of the animals. So any of the pointed weapon or pointed instrument hitting into the body, producing a deep wound, and when it involves the organ of the body, viscera, the body cavity, that's called as a bhinnavrana. A similar instrument producing an injury over the the parts other than that of the body cavity or abdomen and thorax, other than the abdomen and thorax, that's over the limbs. That condition is totally different from the Bhinna Vrana, which is called as Viddha Vrana. Viddha and Bhinna, both of them are they produced due to the penetrating injury, but from Ayurvedic point of view, Sushruta's point of view, Bhinna is related to the cavities of the abdomen, body cavities, viscera, whereas the Viddha is limited to the limbs as such. The types of the instruments which produce injury are the similar. Now, it can affect the kostalgas, and Sushruta describes about the kostalgas in this context. Sanani amagnyapakvanam mutrasya rujirasya cha hridundakapusasya kostha ityabhidiyate. According to Sushruta, kostha is ama agnipakvasthana, mutrasya rujirasya, that's the pelvic cavity. Hridundakapuppa, thorax, also is a part of the kostha. So, kostha is not to be translated as abdomen. Kostha is the body cavity as a whole, which involves both the thorax and abdomen. And consider them as a single structure also has a rationality from the point of view of embryology. Embryologically, both the thorax and abdomen are formed as a single intracoelomic cavity. And later on you have that bifurcation in the two compartments, and hence Sushruta's concept of considering both the cavities as a single entity and naming as kostha is perfectly justified. And there is a lot of other applied aspects also which justify this. Maybe in some other context we will refer to that. तस्मिन् भिन्ने रक्तपूर्णे ज्वरो दाहश्चाते मूत्रमार्गगुदास्येभ्यः रक्तं घ्राणाच्च गच्छति मूर्च्छा श्वास तृट् आत्मानम् अभक्तच्छन्द एव च वीणुमूत्रवातसंगश्च श्वेतास्रावो अक्षिरक्तता लोहगन्धित्वम् आत्सस्य गात्रदौर्गन्ध्यमेव च हृत्शूलं पार्श्वयोश्चापि. Now, when there is an injury to the viscera, the complications can occur could be, when there could be hemoperitoneum or hemothorax. The blood could be accumulated in that cavity, that's a Raktapurna, and which results in the peritonitis or pleuritis, Jaraha, Dahaha, Murcha, Shwasa, these are the complications of the same. Or Mutramargakudasebhya Raktam, there could be bleeding from either any of these natural openings like oral cavity or maybe the urethra or the rectum or so on. There could be bleeding from the natural openings of the body, or there could be a absolute paralytic ileus, Vinmutra Vatasagdaha. There will be paralytic ileus, which are the complications. Absolutely perfect description of a abdominal injury. And Akshiraktata Lohagandhittu Masya and Gandhaurgate. These are certain specific descriptions which are described by Sushruta. And there could be even leakage of the contents of the intestines into the abdominal cavity. In any case of a trauma to the abdomen, whenever you have that, a penetrating trauma would always has to be examined very carefully to identify the injuries of the structures which are comparatively visible. Whereas there is a blunt injury, blunt trauma, the one of the major problem would be the hemoperitoneum. Identification of that Raktapurnata, the hemoperitoneum, and the management is the most challenging issue. Once there is a hemoperitoneum, it's always important to identify the location of the bleeding. So none of the investigations like CT or the other way cannot give you a very clear-cut picture of this. And even to know like how much of the blood has been lost in the peritoneum would be quite difficult to make out, because once there is an irritation, peritoneal fluid will be added to, and hence you have to depend upon only the clinical parameters based upon the stability of the hemodynamic issue, and that's how it has to be seen. Or the bleeding again can be of different categories, different types, like there could be a contusion within an organ like a liver and blood could be accumulated over that, or there could be a frank hemorrhage where the blood may flow out, or there could be even hematoma formation there, or it could be within that capsules of the kidney, like there could be a hematoma formation, or there could be pneumoperitoneum. The gas also can leak through, or there could be a blockade of the vessels, and hence an organ can become ischemic. So all these issues have to be considered in case of abdominal injury. Now, the specificity which is mentioned by Sushila is Vishesham Chatrame Shuna, Amasheste Rudhire, Rudram Chandayat Punaha, Adhanam, Atimatram, Kashulan, Brashadaranam, Pakvashe Gate Chapi, Rujo, Gauramaja, Shitadaja, Adhonati, Kebyo, Raktasya Chagamaha. Now, one of the other complication would be the blood may get stored in the organs like intestines, gastrointestinal tract. Blood which gets bleeding into the GIT can produce the major complications. One of the important complications of the blood in the GIT is it can produce a toxicity. Blood, when it is digested, it produces a huge amount of the ammonia, and that ammoniacal toxicity can produce serious complications. The ammonia locally produces irritation to the gastrointestinal tract, and hence the movement of the intestines becomes sluggish or even completely impaired. There could be a total paralytic ileus, intestines would become dilated. At the same time, the ammonia would be producing the irritation to the nerve endings and can produce cerebral irritation, convulsions, coma, or even death can occur. So whenever there is a huge amount of blood in the GIT due to any reason, whether it is due to the trauma or non-traumatic conditions of the GIT bleeding, one of the first steps to be managed would be that blood has to be evacuated. Of course, the blood bleeding has to be stopped. That's one of the issues. And once the bleeding has been stopped, as early as possible, the blood has to be evacuated. So now in the present situation, when the patient has a upper GIT bleeding, we will be putting a rice tube and then will be a gastric lavage so that the bleeding or the blood will be removed. Or if the patient has the bleeding in the distal portion, then it can be given by enema, removed by enema and so on. So that's exactly the point which is mentioned by Susuda. If the bleeding blood is in the amasha, in the proximal portions of the gastrointestinal tract, it has to be vomited out, chardana. Now, Sushruta has suggested chardana, vomiting. Now we have the facility of the tube, nasogastric tube, the rice tube, which has to be inserted in, and then we can do a gastric lavage, which is not mentioned by Sushruta. Sushruta has suggested chardana, inducing the vomiting. And the clinical signs will be Adhanam Atimatram. There would be the distension of the abdomen due to the paralytic ileus and the pain which is quite severe. Same issue in case of Pakvashayata in the distal area. There again the same issue where the patient would have severe pain, heaviness and the coldness of the periphery. That's due to the shock signs, and there again the treatment has to be removed. Abhinnepi ashe antranam phihi sukshmehi antrapurnam pehidasya gate vedada lakshate tasya gaurav. Another quite important issue is even in case of a non-penetrating injury which doesn't really produce the rupture of the structures, visceral structures, there would be a leakage of the blood from the surface due to the irritation, and that would be producing the sort of a reverse osmosis can occur, and the fluid could be accumulated in the abdomen. So there could be a frank blood or it could be a serous fluid which is produced due to the discharge, and this again is a quite confusing issue. Practically when a patient comes with a blood trauma and the distension of the abdomen could be somewhere in the localized portion, maybe on one side or maybe in the epigastric area or so on, depending upon the location of the bleeding, and that blood has to be removed either both from the peritoneum as well as from the GIT. And later on when you go for the exploration, the whole problem would be like to identify the location of the injury. The general rule to search for that location of the injury is the points of the GIT where a movable part becomes immovable, like the duodenojejunal junction, ileocecal junction, or rectosigmoid junction. These are the areas where the possible impact of the blunt trauma would be more, and the leakage of the blood or serous discharge from these areas would be the usual locations, and they need to be identified, see whether the tissue is viable there or not, and then plan the management. That's the important issue. The next is about the Vidhavarana. the point which I just referred earlier. सूक्ष्मस्य शल्याभ्येतं यदङ्गं तु आशयात् विना उत्तुण्डितं निर्गतं मा तद्विद्धम् इति निर्दिशेत्. विद्धव्रण is a penetrating injury, and that penetrating injury would be over the limbs, not visceral area. Limbs or maybe in the head also. And it can produce two appearances, one Uttundita Vrana or the Nirgata Vrana. Uttundita Vrana is where the wedges are raised, that's what you see in the exit area, and the Nirgata, a depressed wound which is in the entry area. Now, with any of the weapon instruments like either single blade or the double-edged knife or screwdriver or ice pick, etc., the shape of the wound can be slightly changed, but edge of the wound would be having the appearance of either a exit wound shape or entry wound shapes, and these entry wound and exit wound shapes are very typically identified in case of high velocity injuries like bullet injuries. Bullet or such of the instruments or weapons which impact the body with high velocity. The point of entry, the issue, the point, and from the medical legal point of view, these are all quite important issues. Identification of the point of entry and point of exit in case of a bullet injury is one of the important critical issue in the medical jurisprudence, and it's identified by the shapes like the either it's a nirgata in the entry points and uttundita in case of the exit points, and that's how it has to be identified. Then natichinnam natibhinnam ubhayoh lakshanat smritam vishamam radamangecha yattat kshatam abhinirtishet. Ksatavarna is a wound which has a extreme tissue injury, and it is a untidy wound, a significantly untidy wound where there will be a lot of avascular tissues and the tissue can be avulsed. That avulsion of the tissue is the characteristic feature, and that's what Sushila has said. Na achinnam natibhinnam. There is no complete separation, not a total penetration, but there is some injury which is involving the complex organs, and hence the whole organ may become mal-shaped. The shape of the organ, part of the body will be altered. That's called as the ksatavrana, where the tissue loss, tissue injury will be more, chances of the avascularity are more, risks of the sepsis also are more. Then Pichita Vrana is a Prahara Pedanabhyam Yadangam to Prutsadam Sasti Pichitam Vidyata Majja Rakta Pariprutam. When there is a compression of your body, part of the body, either due to a sudden momentum trauma like a vehicular injury, or a gradual compression like a weight load over the body. Now, it could be producing a situation where the whole organ of the body could be flattened, including the bones. Now, in case of the road injury, road traffic injuries, it's very common, like you have that vehicles moving over, and due to that velocity of the vehicle, the movement of the vehicle, the organs involved would be, all organs would be compressed. It's not only the bone. But suppose a similar compression injury has occurred due to a weight which is kept on steady for a long duration, or something like where somebody has fallen and then there is an indirect trauma over the area. In that situation, it could be the bone which is predominantly involved, the other tissues might not be injured to the same extent, and the injury to the other tissues might not be visible. Whereas in a injury like a vehicle moving over the body, the injury of all the organs of the body could be visible. And this is again a complex injury where the whole shape of the part of the body could be flattened, and that's what's called as a Majjarta, we call it as a compression injury or crush injuries. Then Vigatatpagyadangam hi Sangarshad Anyatha Usha Sravanvitam Tattu Gristam Ittipadeshire. Grista is a superficial abrasion where the lesion is limited to the skin and the superficial parts of the body only, and hence it produces a wider surface. In these conditions, there may not be huge bleeding, but the fluid which is leaking through could be serous. When a part of the dermis only is involved, then it could be a serous discharge than really the bleeding. Blood loss is not an important issue, but to cover up the area, to have a primary healing would be quite difficult because the shape would be irregular and the area would be quite wide. And moreover, intensity of the pain in a superficial wound is much more than a wound in the deeper area because the skin is more sensitive. Now, all these different classifications are important to plan the management and predict the prognosis. छिन्ने भिन्ने तथा विद्ये क्षते वा असृगति श्रवेत. Chinna, bhinna and viddha kshata. These are the conditions where the bleeding would be, hemorrhage would be a major complication, and hence your primary treatment would be to treat the complications of the blood loss. And the complications of the blood loss could be of two categories. One, रक्तक्षयात् विजस्तत्र करोति पौनोभृशं स्नेहपानं हितं तत्र तत्सेको विहितस्तदा वेषवारैः सकृशरैः स्निग्धैश्च उपनाहनं धान्यस्वेदांश कुर्वीत स्निग्धानि आलेपनानि वा वातज्ञ औषधसिद्धेश्च स्नेहिः बस्तिः विधेयते. Due to the Raksakshaya, there could be Vata Prakopa, and the Vata Prakopa has to be treated with the Snehapana and so on, and Seka, and the local application of Veshavara, Krishara, etc., or even internal administration of these Veshavara, Krishara also, and Upanahana, local Upanahana, and Dhanyasveda. These are all the remedies by which you have to manage the complications of the blood loss. Now, in the Sutrasthana, when we have discussed about the Rakta Mokshana, there Sushruta has referred to the other issues related to the Raktakshaya, where there would be Pavanashtaparam Kopam Yati Tasmat Prayatnataha. There, the Pavana Kopa, Vata Prakopa is a major complication, and Agni Mandi is the other complication of the Raktakshaya. There, Sushruta has suggested about the substances which can improve the quality of the blood. It has to be Mathuraihi, Anandaihi, these are the substances, Mathura Dravya and not sour substances. They are the substances which are to be given, which can improve the quality of the blood. So, the management of the bleeding would be mainly by attempting to improve the hematogenesis than really the transfusion. Transfusion of the blood is not mentioned there. But there again, there is one specific description. Ati nisruta raktova, raktam pibeta, rakto pibeta srata. If there is a huge amount of bleeding, Sushruta has suggested about drinking of the blood. But the drinking of the blood in compensatory quantities, like if a person has lost 1 liter of blood and you give 1 liter of blood orally, that's not possible because it can produce the same complications which we have discussed. So that's an impractical suggestion. Maybe in small quantities, given 2 or 3 spoons, it can act as a hematonic, it can improve the hematogenesis somewhat rapidly. But anyway, the approaches to the treatment of blood loss, chronic blood loss, would be either it could be giving that relief of the pain and total local management by which the complications of bleeding can be managed, as it's mentioned in this context, or it could be hematinics which can improve the blood loss, and of course the last resort is attempting to cope up with the blood loss by giving blood, which is mentioned as a Raktapana. Now of course we have a choice of the transfusion. Exactly the same similar approach is done now. If it is a mild blood loss, you may not give much importance to that. All that would be important would be to take care of the local issue. If there is a chronic blood loss and hemodynamically the patient is stable, then you prefer hematinics than really the blood transfusion. But if the quantity of the blood loss is quite huge and the patient is not stable hemodynamically, signs of shock are there, in that condition we prefer a volume replacement either with blood or blood products. That issue again we have discussed earlier when we discussed in the Suprasthana as such. So I will not go into the details. Basically, the approaches are similar. The only issue is now you have more technological advances, like a blood transfusion is possible, which Sushruta has not mentioned. That's all the difference. Anyway, पिच्छिते वा विघृष्टे वा नातिश्रवतिशोणितम् अगच्छति वृषं तस्मिन् दाहः पाकस्य जायते तत्र ऊष्मणो निग्रहार्थं तथा दाहप्रभाकयोः शीतम् आलेपनं कार्यं परिषेकस्य शीतलः. In the Pichita and Ghasta blood, because there is not much of a huge blood loss, there is a increased risk of sepsis. The Ushma would be more and Paka also is more. To prevent the Paka, to prevent the sepsis, Shita Alepana and Shita Parisheka, pouring cold substances over the area is suggested. So a measure to prevent the infection is suggested. Shatsu eteshu ethopteshu chinnadishu samasatah jnayam samarpitam sarvam sadyovrana chikitsatam. Once you are able to manage these 6 varieties of the wound in general, it's almost a complete management of sadyovrana or fresh wounds. Now, the specific treatment which is mentioned are अतऊर्ध्वं प्रक्षाम्य छिन्नानां चिकित्सितं ये व्रणाः विवृताः केचित् शिरपार्श्वावलम्बिनः तान् सीवेत बिसिनोक्तेन बध्नीयात् गाढमेव च. In case of the chinna vrana, where the wound surface is either flat or maybe oblique or so on, you have to convert that wound into a tidy wound and then suture. So, vidhina in the sense, you have to suture with a proper care so that the wound is converted tidy. A untidy wound has to be converted into tidy wound. Now, this is one example of that untidy wound converted into a tidy wound. Initially, the wound head was irregular. So, after pruning this, the wound edge is converted into such a shape. So, you will have a projection over here which can be sutured over that depression, that V-shaped projection of the tissue can be sutured over here, and the approximation of the wound edge is possible, and suturing is the first important treatment, and then the bandage has to be done. Whereas in case of another example which is given by Sushila is the ear pinna, injuries to the ear pinna. Of course, injuries to the ear pinna we have discussed in detail in the Karna Vedhabandha chapter. There again you have all the modifications, variables of that which are considered. But the general rule is Karnam Sthanat Apahartam Stapayitva Yathasthidam Sibet Yathoktena Tailena Srodashcha Apipratarpayeta. If the pinna is completely separated, in that condition you have to insert a graft. Now, in the present situation, Sushruta has suggested the same cartilage has to be re-established. Whether the cartilage can be revascularized or not, it's a very complex issue. Chances of a cartilage, ear pinna cartilage, getting revascularized is lesser. So now usually it's the graft which is preferred. Either it could be a total graft of the ear or the grafts of the ear with the different shapes are available, and any of those portions of the ear which has been lost now can be filled up with a graft. That's the present day situation. Sushruta's period, that kind of a graft might not be possible, but Sushruta had attempted to replace the tissue and then maintain the vitality of the tissue by having the taila. Then Krikatikante Chinetu Gachatyapi Samirane Samyan Niveshabadniyat Siviyat Chapi Nirantaram Ajena Sarpishachivam Parishekam Karayet Uttano Annam Samasniyat Shaitacha Suyantritaha. In the injuries of the neck where the trachea or the larynx are involved, laryngotracheal injuries, Sushruta's suggestion is you have to suture and put a band-aid and ensure that the patient would not have a aspiration. So you have to keep the patient erect and then feed. This is what Sushruta has suggested. But now the present protocol is in case of a laryngotracheal injury, you would not close the injury. Instead, you have to maintain the airway by a laryngotracheal tube. A tube has to be inserted, and only after the tube is inserted and the ventilation is maintained, the wound can be sutured. And till the whole issue is over, laryngotracheal tube, this endotracheal tube has to be maintained. Either it could be a laryngeal tube or endotracheal tube has to be maintained, and the wound can be sutured only after maintaining this. So, in the present day situation, you will not attempt to close the wound directly, because a wound which is allowing to make the air to flow through, so where there is a Gachatyapi Samirane, if there is a wound, air flowing through, that's the wound, that's the point which is keeping the patient living. So life of the patient is dependent upon the air movement there. So in the management, the first priority is to give an alternate pathway for the air to move through and then close the wound, not directly close the wound. But anyway, Sushruta didn't have that kind of an approach of a tracheal tube as such, and hence he had suggested the closure of the wound, but he knew about the complications of the aspiration, and to prevent the aspiration, a patient is suggested to be kept in direct posture and given the food. Now of course we have the relationship, and once the tracheal tube is inserted, chances of the aspiration also is reduced. Then, in case of the deep wounds, Shakhas Patitam Siryak, Praharan Vivrtan Bhisham, severe Sammik Nimesha Ashu Sandhyastini Anupurushaha, Badhva Velitakena Ashu Tatas Tailena Sechayeta, Charmana Kopana Bandaha, Karyova Yova Hito Bhaveta. Suturing of the wounds elsewhere, in case of a complex wounds where multiple tissues are involved, You have to go tissues plane by plane. So what Sushra has suggested is, if it is a bone, the bone has to be kept in the proper position, then the next tissue. Of course, bone now we have multidisciplinary approach. Orthopedic approach would be to maintain the integrity of the bone. The issue we will discuss when we discuss the next chapter, the Bhagna chapter. And the other tissues, they have to be sutured layer by layer. If the muscle is injured, the muscle has to be sutured, and then the tissue has to be sutured, the skin has to be sutured. Skin suture, again, you have to ensure that the whole depth of the skin is covered fully with the suture. To facilitate that, you can have many modifications. Either it could be multi-layer sutures, like you may put a suture at the deeper plane, make it superficial, and then close the edge, or you have the different movements of the thread, like a knot, a figure of 8 type of knot could be placed by which the depth can be covered. But the important is the depth has to be covered and the pressure on the edge is uniform. And then after you have suture, Sushra has suggested Virvitaka type of the suture. A continuous suture is suggested by Sushra as an option. And the different types of the sutures we have discussed in the Sutrasthana earlier. Then Charmana Gofana Bandha, after the suturing, there has to be a thick supporting bandage, has to be placed. Then Prishte Brano Yasya Bhaved Uttanam Shayettam, Ato Anyatha Cha Urasije Shayet Purusham Branaya. If there is a wound on the back, then the patient has to be kept in a supine position. If the patient wound is on the anterior portion of the chest or abdomen, then the patient has to be kept in a prone position. Now, by this, you can ensure that there is a drainage of the fluid which is accumulated. So, in case of a visceral injury, one of the important protocol is they ensure that there is no accumulation of the fluid and drainage is there. Now, in the present day situation, we have the option of putting the tubes in. So, in a abdominal wound, we will put a drainage tube into the abdomen. In thorax also, you have that thoracic tube to be inserted in, and then keep drainage. Once you have that drainage tube in, whether you keep the patient in a prone or supine position doesn't make much difference. But Sushruta didn't have that facility of a tube inserted, and in that condition, to prevent the sepsis, its patient is nursed in such a position so that whatever the accumulated fluid will be drained out. So if the wound is on the back, then the patient has to be kept in supine position. If the wound is on the front area, patient has to be kept in the prone position. Chinnam Nishesharam Chakam Dadha Tailena Buddhiman Badniyat Koshabandhena Praptam Karyancha Ropanam Chandanam Madhukam Rogdram Utpalanin Priyangavaha Haridra Madhukam Tiva Payasyat Atrachastamam Tailam Ebhi Vipakuntu Pradhanam Ranaropanam. In a case of complete amputated limb, Sushruta has suggested to cauterize the area with the heated oil. Now, of course, in such an amputated wound, the most important problem would be the hemostasis to stop the bleeding. The rest of the bleeding now is done by either ligatures or maybe cautery. Sushruta has suggested a generalized cautery with the thaila, which may not be practicable now. And then after that, you have to have a capsule, koshabandha, and the patient has to be treated with ropana. Ropana can be done with thaila of chandana, madhuka, rodra, uttara, etc. And this ropana thaila is suggested as an option of treatment. Or Chandanam Karkatakyam cha sahe mamsarpaya amrita hare nama mrudalam cha trifala padmaka utpale Triyodashantam Trivitam Metadvapayasanitam Tailam Pakum Sekarte Hitam Branaropane. One of the other Branaropana Yoga mentioned is a Triyodashanta Taila, which has that 13 substances which are added in. Adavurdham Pravakshami Bhinnanam Chikitsidam Bhinnam Netram Akarmanyam Abhinnam Lambatet Yata Tannimesheta Stanam Avyavidha Siram Shanihi Pidayet Padina Samyak Badna Patrantarena to Tato Asya Tarpanam Karyam Nasyam Chanena Sarvisha. Ajam Bhrisam Kshirapatram Madhukam Charpalanicha Jiva Karusha Bhagavativa Pishva Sarpi Vipachetat Sarva Neta Bhigatetu Sarpi Retat Prashasyate. In a Bhinna Vrana, which involves the cavity of the eye, where the eyeball has been protracted out, has been pushed out, and it's hanging. Netram Akarmanyam Abhinam Lambate, where the eyeball is not ruptured but the whole eyeball is protruded out. In such an injury, Now, that kind of an injury is possible only somebody attempts to put the knife in and then the whole eyeball is pulled out. In those days, that was one of the form of the punishment to criminals, like the eyeballs would be extracted out. And if such injuries, Sushruta had suggested try to re-establish the eyeball condition if the blood flow to the eyeball is maintained. Avyavidha serum. If the sira or the blood vessels of the eyeball are not affected, in such a condition, put the eyeball into the socket back and then put a pressure, mild pressure, and put a bandage with the Padmapatra, the leaves of the lotus plant. Of course, how far we can manage these eyeball injuries in that manner by re-establishing the eyeball is questionable. But still, in a hypothetical situation, this may be a practical issue. But practically, you may not have that kind of an injury where the integrity of the eyeball is not affected, but the eyeball alone is pulled out. Anyway, that's what Sushruta has suggested. And in case of any other injuries, even other forms of injuries to the eyeball, one of the common suggestion or the prescription would be Ajam Grisam, the goat's ghee, Kshirapatram, Madhukam, Chagutpalani, Jiva Karshibaku, Jaiva Pishtva, the Taila Grista prepared with the goat's ghee and Madhuka, Utpala, Jiva Karishapaka, etc. That's one of the prescription for all forms of the eye injuries. Then Udarat Medasovarti Nirgata Yasidehina. कषाय भस्म मृत्कीर्णां बद्ध्वा सूत्रेण सूत्रवित् अग्नितप्तेन शस्त्रेण छिन्द्यात् मधुसनायित बद्ध्वा व्रणं सुजीर्णे अन्ये सर्पिषः पानमिष्यते स्नेहपानात् ऋते चापि पयःपानं विधीयते शर्करा मधुयष्टिभ्यां लाक्षया वा स्वगंसया चित्रा समन्वितं चैव रुजादाहस विनाशनम् आटोपः मरणं वा स्यात् शूलो वा अच्छिद्यमानया मेधो ग्रन्थौ त्यक्तैलं वक्ष्यते तच्च योजयेत्. In a penetrating injury of the abdomen, if the mesenteric substances are they would be projected out. The fatty layer of the abdomen is projected out. In that condition, that has to be cut off. The fatty layer has to be cut off as such after having it treated with the kashaya and bhasma, and it has to be even maybe agnisaptena shastrena with the heat and rod. It has to be cut off. So that's how to maintain the sterility. So removal of that fatty substances are the important issue. Then the wound has to be closed. So if it is only the fatty substance which is projected out, then it has to be removed as such. It can be excised. But if it is the intestinal loops, it cannot be excised. It has to be replaced. So after removing of these fatty substances, then you will have to suture the wound, and the patient has to be nursed with the easily digestible liquid food. So Snehapanam Payapanam Vijayate Sharkara Madhyastibhyam Lakshaya Swadamsaya. These are the substances which could be given. If it is not treated or if it is not removed as such, then it may be fatal. It can produce the peritonitis, and fatal complications can occur, or medogranthi, a lump may be formed there. Of course, in the case of penetrating abdominal injury, the general protocol is in the present days paradigm of or logarithm of treating that patient would be, if the patient has a positive, a confirmed peritoneal penetration, then laparotomy is more suggestible now. So you have to open and then identify the issue. And uncertain peritoneal penetration, where the peritoneum is not confirmed to be penetrated, then you have to go for the diagnostic entities. And if it confirms a positive peritoneal penetration, then again it has to be laparotomy. Or in uncertain conditions, laparoscopy is preferred, so that if there is any injury inside, it can be confirmed, and if it is so, you have to go for the laparotomy. If not, if there is a non-peritoneal penetration, then the simple wound management is suggested. That's how the logarithm is done. Then Tvacha Atitya Siradhini Vitva Va Parihityava Koste Pratishthitam Shalyam Kuryad Bhuktan Upadruvat. Now, if there is a real penetrating injury into the abdomen and the intestines are injured, in that condition, the management will be quite difficult, and it can produce the major complications. And in all such conditions, The one of the important issues is you have to confirm whether the patient's hemodynamic stability is maintained or not. Hemodynamic stability is assessed by the signs of the shock. The signs of the shock are cold, clammy limbs, and the impaired consciousness, and postural hypotension. That's exactly what's mentioned by Sushruta as antarlohitam, when there is a bleeding which is in the cavity. And the signs of the shock are Shita Padakarana, cold, clammy limbs, Pandu, he will be pale, Shitotchvasam, the respiration would be faster, and hence the temperature of the air breathed out would be not the same as that of the others. Anadanti, distension of the abdomen, Raktanetram, there will be a stagnation of the blood in the capillary circulation, and that's why the conjunctival infiltration would occur. Then the management otherwise would be Amasheste Ruzira Vamanam Paktimchire, Pakwasheste Deyanche Virachanam Asamchep, Asthaparam Nisneham Kari Musnehim Shodhanehi, Yavakola Kurathanam Nisnehe Narasenava, Punjita Annam Yabaguma Pibet Saindava Sayutam, Atini Sutraktova, Bhina Kosta Pibeta Sarkar. The same point which I referred to earlier, in the Atini Sutrakta, if there is a severe bleeding, then Asrutpana, Raktapana is suggested. In other conditions, if the blood is accumulated in the Amashaya, it has to be with the Omana. It's the same thing which I referred to earlier. It's a repetition. Pakwashaya is the Birecharam. In the Pakwashaya, it's a Birecharam. Then once the blood is completely removed, then Asthapananjani Sneha. Without Sneha, Asthapana has to be given with the Shodhana Asthapana, so that whatever the removal of the residual of the blood is there, it has to be removed. So removal of the blood from the GIT is the important issue. But it's Sushruta knew about the complications of blood. At the same time, there is a suggestion to give blood orally. So these are the controversies which we cannot justify. Anyway, then the patient has to be nursed with a gradual enhancement of the nourishment from Nisneharasa, Anna, Yavagu, etc. Swamanga Pratipannasi Yasya Vidmutramarudaha Vipadrava Sabhinnepi Koste Jivati Manavaha. If the movement, the peristaltic movements are established, if the patient is able to pass the flatus and stools as well as he is able to consume the food, then even in a case of Bhinna Kosta, injury to the peritoneum, patient may survive. That is the important sign of recovery. Abhinnam antram nishkrantam praveshyam nanyatha bhaved pipilika shirograstam tadapyekya vidantitu prakshalya paisa digdam trana shonita पांशुभिः प्रवेशयेत् कृतनकः घृतेन आक्तं शनैः शनैः प्रवेशयेत् क्षीरसिक्तं शुष्कम् अन्तरं गजापुलन् अङ्गुल्या अभिंशेत् कण्ठं जलेन उद्वेजयेदपि हस्तपादेषु संगृह्य समुत्थाप्य महाबलाः भवन्ति अन्तःप्रवेशस्तु यथा निर्धुनीयोस्तदा तथा अन्त्राणि विशन्ति अन्तः स्वां कलां पीडयन्ति च. If there is a injury, penetrating injury, and the intestines get got projected out, they have to be replaced. And again, before you replace, whether you confirm whether there is a perforation or not. If there is a perforation, that has to be suture. And now the present protocol also is exactly the same. If there is intestines or any visceral organ which is penetrating out, it has to be ravaged, cleaned, and if there is a perforation, that perforation or tear has to be treated, and then it has to be replaced in. Now, replacement of the organs into the abdomen now is not a very major issue, because under the anesthesia, when the muscles are relaxed, they can be easily replaced and then you suture it. But without anesthesia, when the muscles would be very rigid, replacement of any loop of intestine into the abdomen would be a real task, and it's not that easy to get across the tone of the muscles. So, Sushruta suggests about either initially try to manage by local pressure. If it is not possible, make the patient vomit out, having a vomiting reflex, so that where there will be intermittent contraction and relaxation of the muscles, during that phase of the relaxation of the muscle, you may be able to push it out, and to make the patient vomit out, Jalena udvejayat, kantham udvejayat, you have to touch the palate of the patient and then induce vomiting reflex. If even this also is not possible, then there is a very unique suggestion. Two of the assistants would have to hold the patient from the hand side and on the head side and the leg side, and they have to just swing the patient here and there, and during that swinging movement, then the patient, these intestines may be pushed in. That looks very crude, but practically in a situation where the patient is not under anesthesia. Of course, with the anesthesia, none of these issues seem to be quite interesting issue, because under anesthesia, when the muscles are relaxed, the whole job is a very easy job. But without anesthesia, in pedal, you have to do all these. They look quite relevant, like to push the intestines in. Then to suture the wound, Sushruta had suggested use of ants. Pipilika is suggested as one of the options to suture the wound, where the chitin would be an absorbable suture. Then व्रणानुपत्वात् भूत्वात् दुष्प्रवेशं भवेत् तदा अपाठ्य प्रमाणेन भिषगन्त्रं प्रवेशेत् यथा स्थानं निमिष्टे च व्रणं सीवेत् अतन्त्रितः. Now the same, if even after these kinds of the attempts, if it is still not possible to push the intestines in, then you have to extend the incision. Incision has to be extended, the wound has to be extended and widened so that the intestines can be placed in. So by all efforts, you have to push the intestines in. And once you have pushed the intestines in and then suture them, then स्थानात् अपेतम् आदत्ते प्राणान् गुपितमेव वेष्टयित्वात् पट्टेन घृतसेकं प्रलापयेत् घृतं पिबेत् सुकोष्ठं च चित्रा तैलसमन्वितं मृदुक्रियार्थं शकृतः वायुश्च अधप्रवृत्ते ततस्तैलमिदं पूरयात् रोपणार्थं चिकित्सकः त्वचो अश्वकर्णधवयोः मोचकी मेषशृङ्गयोः शल्लकी अर्जुनयोश्चापि विदार्याः क्षीरणां वा बलामूलानि चाश्रित्य तैलमेतं विपाचयेत् व्रणं संरोपयेत्तेन वर्षमात्रं यतेत च. After the re-establishment of the organs into the abdominal cavity, you have to make sure that the patient is able to pass the stools, and to facilitate that, mridukriyatam shakrata, to make the stools soft, and vayushtha pravte, to maintain the normal peristalsis. Sushruta has suggested taila of different categories, ashokarna, dhava, these are the substances they are used. Now, of course, it may not be that oral administration. What we do is prefer to do is keep the patient nil orally and maintain the parenteral nourishment, and if necessary, you will have to promote that peristalsis with the parasympathomimetic drugs. Of course, incisions of these areas which are preferable are the better instrument as such. No, that's it. We'll just leave it at that point. पादौ निरस्तमुष्कस्य जलेन प्रोक्षच अक्षिणी प्रवेश नित्तुनसेवन्या मुष्कौ सेवयेत् ततः परं कार्यो गोपनिकाबन्धः कट्याम् आवेशयन्त्रकं न कुर्यात् स्नेहसेकं च तेन च क्लिद्यति व्रणः कालानुसारी अगुरु एला जाति चन्दनपद्मकैः शिला दार्वी अमृतातुक्तैः तैलं कुर्वीत रोपणम्. In case of a scrotal injury where the testicles are projected out, scrotal cavity is opened and the testicle is projected out, try to replace the testicle into the scrotum and then suture, as you do in case of hydrocele surgery, and then a gofana bandha has to be put in if necessary, and the yantrana, the knot of that gofana bandha has to be put on the kati over the pelvic area. That's exactly what we do, the T bandage. And sneha seka should not be given. Sneha should not be given at that area because it can induce the sepsis. शिरसो अपहृते शल्ये बालवर्तिं निवेशयेत् बालवर्त्यां मदत्तायां मस्तुलुङ्गं व्रणात् स्रवेत् हन्यादेनं ततो वायुः तस्मादेवम् उपाचरेत् व्रणे रोहति चैकैकं शनैः बालम् अपक्षिपेत्. Now this is again another unique type of the treatment which may not look practicable now. In a case of skull injury where there is a leakage of the brain tissue, the mastulunga, brain tissue is projected out, Sushruta suggested to close that aperture, close that opening in the skull bone with a tuft of hairs and then make the patient recover. And as the patient recovers, as the wound is healing, you gradually remove one by one hair from the tuft so that there is a gradual healing without affecting the sealing of the skull tissue. Of course, in the present day situation, this may not be a very practical issue. Removal of the skull bone may not really harm the patient. Instead of putting that, closing the aperture, it's better to keep that aperture open so that there is not much of an increase in the intracranial pressure. So only the meninges, the layers have to be sutured properly and ensure that the brain hairs doesn't get the pressure. That's the present protocol. So intracranial pressure should not be increased. Now, whatever the means you do is accepted now. Whereas Sushruta had suggested a closure of the aperture, which is not the standard protocol now. Then Gatra Daharte Anyasmart Snehavartim Pravesha the Krite Nishodam Chapi Vidhi Satyakshate Hitaha. In any other portion of the body where if there is a tissue loss, that tissue loss has to be filled up with a sneha varti, a wick with sneha, and then it has to be gradually filled up. So maintenance, now it's the same thing which we do. Wick is usually used or a pack is done so that the tissue would be having sufficient pressure, and once the healing occurs, you can remove the pack. दूरावघटः सूक्ष्मः स्युः व्रणाः तान् विशोडितान् कृत्वा सूक्ष्मेण नेत्रेण चक्रतैलेन तर्पयेत् समङ्गां रजनीं पद्मां त्रिवर्गं तुत्थमेव च विडङ्गं कटुकां पथ्यां बुडूचिं सकरन्दिकां संहृत्य विपचेत् काले तैलं रोपणमुत्तमम्. In any other wounds, the general rule is you have to ensure that there is no foreign body or no irritant object left over. So you have to, and then hemostasis has to be established. So all the shalyas have to be removed and hemostasis has to be established, and then after that you have to suture the wound with a fine thread, sukshmena netrena, and then chakra taila has to be used, or the other taila of samanga, rajani, etc. can be tried. Or the other Guropana taila or ropana ghritas which are suggested are Talisham, Padmakam, Mamsi, Harenum, Agurchandanam, Haridre, Patnam Pijani, Soshiram, Madhukam Chirehi, Pakum, sadyovrana, Shuktam, Tailam, Ropanam, another of the Ropana taila. Kshate, Kshatavidi Karya, Pichite, Bhagnavaditi. In the Pichita Bhagnavat treatment has to be like that, Bhagna. In Kshata, the same protocol of treating the wound is done. Griste Rujaha, Nigrishyashu, Churnehi Upacharet Bhranam. In a superficial abrasion, pain management is the one, and then Avachurnana, dusting is suggested. Vislishtadeham Patitam Machitam Hatamemacha, Vasayat Tailapurnayam, Dronyam, Mamsarasasanam, Ayameva Vidikkarya Kshine Marmahatetata. In a very gross injury, and multiple injuries are there, and throughout the body there are wounds and different types of wound. Such a condition, patient is suggested to be kept in a tailadroni, a deep, rather a tank containing taila, and the patient is kept over there, nursed over there, which is again unique, may not be having a practical significance from the present day's point of view, but all the attempt is to prevent the sepsis, to keep the patient in a tank filled with taila is suggested. I don't say that you have to do it now. So from the practical current point of view, this may not be very relevant. Then Ropane Saprisheke Panecha Pranam Sada Tailam Brisam Vasainujam Sharira Rutun Avekshhi. In all Ropana or Padisheka, local application, taila or Grita are suggested. Grisnani Yani Bakshami Yatnataha Bitta Bittadu Sadyovrana Deyani Tani Vaidyana Janata. In the Pitta Chikitsa, the Gritas are mentioned, and those Gritas can be used in Sadyovrana as a Ropana treatment. Satyakshatavanam Vaidyaha Sashulam Parishetetu Sarpusha Natistena Balatelaina Vapunaha. Into one of the remedies to reduce the pain would be a Balataila is suggested, which is warm Balataila applied over the area can reduce the pain. Samangam Rajanim Padmam Patyam Tam Suvachalam Padmakam Rodhanadukam Vidangani Haredukam Talishapatram Naradam Chandam Padmakesharam Manjista Shira Lakshasta Kshiram Chapter Pallavan Priyala Bijam Tindukya Karunani Palanija Yatharam Samahritya Tailam Ebi Vipajeta Sadyovranam Sarvesham Madhustanam Ropnam. A Sadyovrana Ropanam Taila which is suggested, which can be prepared and tried, of course. The contents are same, Samanga, Rajani, etc. All majority of them are Shitavirya, Kashaya, Rasadravyas. Kashaya, Madhura, Shita, Kriya, Snitha, in general, Kashaya, Madhura and Shita are the suggested treatment. Sadyovrananam Saptaham, Paschat, Purvoktum Achareta. All the treatment of Sadyovrana, Shita, Kriya and Kashaya Rasa are suggested for the 1 week, and after that, it has to be considered as a Dustavrana. Dustavranash Kartavyam, Urpham cha Adasya Shodhanam, Vishoshanam Tata Aharaha, Shonitasya Mokshanam, Kashayam Rajavuksha, Sarasavatya Dhavanam, Tayoreva Kashayana Tailam Shodhan Mishre, Ksarakalpena Vatailam, Charadravyesha Sadhikam. In the Dusavrana, the protocol of Dusavrana which you have discussed in the previous chapter, Shastri the program, they are suggested. But there again, the general principle would be Shodhana is suggested, and then the Ahara, food, and Raktamokshana, and Kashaya for Shodhana and the Ropana, they have to be followed. And there again, for the Shodhana, some of the yogas mentioned in this chapter also, previous chapter also, the same are mentioned. And Dravanti Chirapilvasya Danti Chitrakamevaja Prithvika Nimapatrani Kasisam Chittamevaja. त्रिवृत् तेजोवती नीली हरिद्रे सैन्धवन्तिलाः भूमिकदम्बः सुवः सुखाख्या लाङ्गलाह्वय नैपाली जालिनी चैव मदयन्ती मृगादिनी सुधा मूर्वा अर्ककीटा कीटादि हरितालकरञ्जिकाः यथोपपत्तिकर्तव्यं तैलम् एतैस्तु शोधनं कृतं वा यदि वा प्राप्तं कल्काः संशोधनास्तथा either shodhana taila or shodhana ghृta or shodhana kalka can be prepared with the above drugs as such. Or similarly, Saindava, Trivurta, Yeranda, Patra, Kalkastu Vatike, Trivurta, Haridra, Madhukalka Paite, Tilayutaha, Kapaje, Tila Telo, Tila Tejo, Danti, Swarjika Chitrakaha, Dustabrana, Vikaryo, Mea, Kustabraneshwapi. In any of the Dustabrana, the selection of the drug would be based upon their doshagna property and they have to be prepared. षड्विध प्राक् प्रदिष्टो यो सद्योवृणनिश्चयः नाथ शक्यं परं वक्तुम् अपि निश्चितपाठिनः उपसर्गे निपातैश्च तत्तु पण्डितमानिनः केचित् तु संयोज्य भाष्यन्ते बहुधा मानगर्विताः बहुतद्भाषितं तेषां षट्सु एव अवतिष्ठते विशेषः इव सामान्ये षट्त्वं तु परमं मतम्. All the wounds can be classified under only the 6 categories, and if anybody says that there would be more than that, that's not acceptable. That's what Sushruta says. And you may have large number of these words by adding either upasarga or the nipata. Upasarga and nipata is quite an interesting issue from Sanskrit Vyakarana. Upasarga is upasargena dhartvartha balad anyatra niyate prahara ahara samhara vihara parihara. By adding one letter or one word to another word, the meaning can be changed. Like hara, the word meaning is mala, whereas when it's added to prahara, it's the hitting, ahara, food, and so on. Then nipata is padapuranaha. Nipataha nama arthavashat nipatanat arthakanam vitareta arthakaha sartakaha. To fill up the shloka, to fill up the number of letters in the shloka, you may add some na, cha, na, ni, tu, and so on, which may not have a different meaning, a definite meaning as such. So by adding such of these, you may have innumerable number of words to suggest the names of wounds which are not applicable. You have to consider only the 6. That's what Sushruta has said. With this, we conclude today's chapter. It is Sushruta Samhitayam Chikitsasthane sadyovrana Chikitsam Nama Dvitiyo Adhyayah. If there are any questions, then right, there are a few questions. What is the difference between Pichita Sadyovrana and Pichita Bhagna? Pichita Bhagna, of course, they are both of the issues are similar, but in Pichita Bhagna, the priority is about the bones, and Pichita Vrana is priority to the surface bone. That's all. Otherwise, they are similar. Then Amashayastha Rudhira Vamana and Pakvashayastha Virechana indicated can be considered as a stomach lavage and or aspiration for upper GAT bleeding, and laxatives given for GAT bleeding. Okay, that's true. I would consider the Vamana as the lavage. Now, for GAT bleeding, instead of giving a purgative, we would be preferring the enemas so that it's evacuated. So that would be more effective. But of course, if it is in the small intestine, you have no choice. It has to be the virechana. Purgatives have to be given. And would this understanding be correct for woman and virechana mentioned here, since it's a article? No, in this condition, when it is about the vamana, it's not word used. Vamana is not the word used. Chardana is the word used. Chardana is inducing emesis without the protocol of pura karma. So it has to be understood in that manner only, because it's a situation where you do not have the time to have the snehana, and then pura karma is not to be done. So in this, it's not the word. Sushruta has used the word very typically, the chardana, not the vamana. Chardana, it has to be understood as a something like inducing the vomiting without the protocol of pura karma. Okay, that's all. Right. So we will conclude that.